So we know that based on the HERIZON study, the Zanidatamab was looked at in a single-arm phase 2 study, looking at patients who were HER2 positive. And in that study, based on the durable response, that the drug was approved by the FDA in refractory setting in patients who are IHC 3+. However, as you know, this was not a randomized study. So the question that we tried to ask was, how much better is it compared to a regular standard chemotherapy arm? Because there won't be a randomized study, that we will never know the answer. So what we tried to do was that we tried to create an external cohort that looks very similar to the HERIZON data by looking at the Flatiron database, looking over 20,000 patients. And what we tried to do is that we tried to look at the inclusion criteria of HERIZON and try to find the same match inclusion criteria based on the Flatiron database. And what we found out was that there were about 12 patients that matched the inclusion criteria from the HERIZON data. So we know the HERIZON data, there were about 62 patients who were IHC 3+, and in the Flatiron database, there were about 12 patients. Now, what we tried to do is that using what we call a standardized, we're trying to use a mortality standardized ratio, we're trying to balance those two factors in and try to compare those two arms. Understanding that it's not a perfect example of a comparison. By comparing those two arms, we found that control arm with regular chemo in the HER2-positive patients had an overall survival of about 3 months, that's expected, of the PFS about 2 months, as expected. However, the patient that were on the Zanidatamab had a remarkable overall survival close to 18 months and about tripling of the PFS, telling us that in patients who are HER2-driven tumor, that Zanidatamab or HER2-targeted drug is much more effective than the regular chemotherapy that we would give, telling us that in those patients, definitely the Zanidatamab or a HER2 drug should be used in second-line setting. As of right now, Zanidatamab is approved in second-line setting, and we know that HER2-driven BTC tumor, there is definitely a survival advantage of using not only Zanidatamab, but there are other HER2 drugs showing response rate that is very durable. So there's no doubt in my mind that not only based on our data to be presented, but based on the other data that's out there, including a prospective phase 2 study with HERIZON data, that really a HER2 drug should be considered standard of care in patients who are HER2 IHC 3+ in this disease. I think right now, the indication right now is for in a refractory setting in patients who are IHC 3+. Obviously, if it works in the second line setting and beyond, is that you go into first line. So currently right now, the Zanidatamab and other drugs are being studied in first line. Is that can you bring this drug a lot earlier to not only increase PFS, but overall survival, and at the end change the course of disease so that these patients live longer.